Okay, hi everybody. It is May 21st, 2021, and we're doing with Fridays with Feldman. And we are going to do a repeat topic today, or a topic that I've discussed before, but I'm going to really specifically discuss why fusion today. We're going to discuss the achondroplastic spine, or the spine and achondroplasia. But this is not going to be a talk about the specifics of science. This is going to discuss really the patients. And I'm going to show a few patients, and then I'm going to follow this with one of the people who works with me is named Kristen, actually has achondroplasia, and I'll present her, I'll show her case in here before. That's where I met her from. And I just want you to see about the spine and then hear from patients later on. So on my website and perhaps on social media, we're going to start posting patients who've had spinal problems with achondroplasia and telling their story. And I think that's what we have to hear. And the impetus for me to talk about this today is that I've looked at the blogs and I've heard from Kristen, heard from other people, that people are so frightened about this word fusion. Why a fusion? Why are you welding my spine together when it moves? And I'm going to try to explain why most of the time we have to do that, but not all the time. So the problem in achondroplasia of the spine is stenosis, and I'll describe in a second in pictorial version what stenosis is. But basically, it's the biggest problem that adults have with achondroplasia. I mean, other joints can become arthritic and other joints can become problematic, or bow legs and things like that. But the biggest problem for adults, and I treat patients with achondroplasia literally from birth until octogenarian, so they're 80-something years old. And I've seen the whole spectrum of children and adults with achondroplasia. And the number one problem why people are not working, the number one problem why people are on pain medication, the number one problem why people are retiring young or not enjoying life is because of the spine. And the spine is stenosis. And this is a gentleman who I met who had that stenosis, and he waited until he was old. He was paralyzed. In this case, he's 50-something years old. And they decompressed the spine. They made the spinal column wider, but you can see he's leaning forward. You can see how the spine is completely bent forward, and suffering and literally looking at the ground. That's called kyphosis, and he's bent all the way to one side and leaning all the way forward. So what is stenosis in pictorial terms? So I was trying to find a way to describe that. Well, the spinal canal, in this case, would be the tunnel. The trunk would be your spinal nerve roots if you have achondroplasia, trying to get through that tunnel. So if you're trying to send a signal, like Amazon's doing in this tunnel, trying to get through that tunnel, they cannot. They cannot get through the tunnel because the nerves are stuck in the tunnel. And then they crash together into one big mess. And I think people who have spinal stenosis severely really can view this car accident as how they feel in their spine, what their nerves feel like as each one bangs against the side of the tunnel, which is your spine. If you don't like that analogy, you can send me issues of ones that you like better. So we asked this questionnaire, and I've told you this before. Every time we operate on a patient with achondroplasia, we ask a bunch of questions from the patient before we do anything. Do you have weakness? Are you unable to hold your urine in? Are you limited to how far you can walk because your legs get tired? Do you find yourself squatting after walking? Very, very common. So, and when we ask, how far can you walk? Is this limited more than it was before? And these questions about legs becoming tired, about urinary incontinence, about squatting when you walk are all extremely important in deciding whether or not you need an MRI and whether or not there is spinal stenosis or not. And those are the symptoms: back pain, leg pain, numbness, tingling, heaviness, inability to hold urine or feces or from the bladder or bowel. After you walk a lot, basically it becomes painful or tired in your legs. That's called neurogenic claudication. And oftentimes it opens up that tunnel when someone squats, and it's relieved by squatting or sitting. There are in chairs if you're hiking. So a mother will tell me that a child is walking in the woods, and every literally 10 steps, they stop and they squat. And then they feel better, and then they walk on. And that would be neurogenic claudication. So this is the young woman I was talking to you about. She was 30 years old. She presented 5 years ago. And this is my way of saying it's not always simple, right? I mean, so this young woman presented with paralyzed or partially paralyzed, couldn't move her legs, severe pain. And it really went pretty quickly from a time when she was very, very functional to being unable to do anything at all almost the morning of surgery. And what I see when I look at this is I see a relatively straight spine from the front, but you can see this kyphosis. That's the roundness from the front of the spine, the roundness from the side of the spine. That kyphosis presses against the nerves in the back at this level. And that's what happens. And so these are the nerve roots. The nerve roots these are the cars coming through the tunnel. Each one is getting stacked up. It can't run through. So in this case, you're looking at these nerve roots right in here, and right through here, and right here where the disc is. This is a disc. These are discs. This is the L3, L4 disc. Let's see if I can. There, that's the L3, L4 disc pressing against the nerves, pressing against the nerves. Here's a clear tunnel all the way down below. So down here, you have a very clear tunnel, and here the tunnel is being compressed, particularly where the kyphosis is, particularly where you're seeing where that roundness to the back is. And this is looking at a cut, and I can tell her, you can see that there's no water, there's no room for the spinal roots to get through that tunnel. So this is these are the nerves coming down into the tunnel, and they're basically crashing into the bone as they come through, and that causes a lack of function. And so this is one solution, right? We go ahead and we open the tunnel. But if you have kyphosis already, if you're leaning forward, if your spine has that, which is common in achondroplasia, then it has to be fused. Otherwise, it will keep falling forward, and you'll get stenosis again. So you have no choice but to fuse it. Now, it's not easy to fuse because we're taking so much bone away to get the compression. And that's been an evolution for me, certainly, and why it's not simple for fusions to occur even, and where the horror stories that you hear online are about, but you have to go through the process. So in this case, L3, L4 did not fuse. Sorry. L3, L4 did not fuse, right at this level on the bottom, and that's common. So what you can do, what we've done, is we've started putting from the side a small incision and putting what's called a cage. And here you see, after that cage is inserted into the front to make it fuse in the spine in the beginning. And I do that from the beginning now. So maybe that was 5 years ago, and today you do it from the beginning. And if you look here, so the spinal cord was coming down here. We didn't open it here. But if you look right in here, you start seeing that it's open. And that's because that's what happens. And then this cage fuses it. It's now 5 years later, and the spine is fine. Perfect? I don't know if it's perfect, but it's fine. Okay, so it can happen in a 30-year-old, but it could also happen in a 10-year-old. So here's exertional stenosis. What does that mean? This child was walking along he has many siblings, and he can't keep up, and he has to squat down literally every 20 steps. So even in a 10-year-old with that much kyphosis, as right in here, this child has spinal stenosis, even at this age. And that is basically important to know that it can occur in this age as well. And so the same thing occurred. Now, he's very young, he doesn't need to have that side view, but I can't just decompress him. I can't just open the canal because he will fall forward. So we do a short level fusion with instrumentation. And he's running around with his brothers and sisters, and nothing will stop this young little boy. Their family moved to Florida. They have a few kids with achondroplasia, and they have moved to Florida, and we see them all the time. So I know him very well. This is a young girl who called. She's 14 years old, and she basically has urinary incontinence. She can't hold her urine. It's becoming progressive. Can't walk on the distances she used to be able to walk either. So the reason why I'm trying to show some of these other cases are, besides I think you'll hear their stories online over the coming weeks, is because this young woman was so close to becoming paralyzed that even when I brought her to the operating room, so I brought her to the operating room, and I placed that cage in that we do automatically now, right? So we go through a small incision on the side, and so we make sure it fuses at L3 and L4. Well, as I turned her onto her belly, I couldn't monitor her spinal cord. So the spinal cord even didn't function just from lying on the belly, just from straightening out the kyphosis. That was enough to compress the spinal cord. We can monitor that. So we turn her back over, and she's fine. and we went back in, and I actually did the surgery with her in a V position, almost had to decompress the spine with her maintaining the kyphosis until I could open that tunnel and make room for the spinal cord. And she went home and is fine, walking around and doing everything. And there you see the kyphosis is corrected, and basically this is helping fuse that bottom part that we ran into trouble with. So it's not like we're never going to run into trouble. I don't think that this is a simple idea to think about, but I think that it's something that certainly can be treated and can be fixed. And if it needs something else done, then that can be fixed as well, which occurs in a complex spine surgery. But it's certainly the patients and the people can have productive, non-painful, functional living. And that, to me, is really the goal for the treatment of the spine in achondroplasia. Do we always fuse? No. Here's a young man, actually. A young woman who had no kyphosis. So in this case, I can just decompress and not, so just open the tunnel and not have to do the fusion and the rods. But that's more rare. I would say 20% have this and 80% need to have the fusion. And even this young boy, I'm not going to keep on showing cases and he may speak, we even had it to his pelvis. He couldn't even sit on the plane coming here from Colorado, I believe. And he couldn't even sit on the plane without so much discomfort that he was really crying on the plane. And he went home and is doing perfectly well after decompression and fusion. And I had to go to his pelvis because his stenosis was way down on the bottom. So this is a spine, this is without kyphosis and does not need to have a fusion. So again, back to that man, yes, you have to finish the story. It may be better just decompressing, but this is not acceptable in my opinion. And this is the result of non-fusion if someone has kyphosis. So I think we need to understand that it's not about whether or not fusion is you want a fusion, it's whether or not it's necessary to achieve the results of full function. And nothing comes without a trade-off, that's true. For instance, many times after fusions of the spine, people want their arms lengthened because they can't take care of themselves as well. And that's really important. And that's happened and I tell patients that from the beginning, that if we have to fuse your spine, you may want your arms lengthened. Much more so than your legs because it's a functional issue of caring for yourself. And you can't bend as easily. And so therefore you'd want to have your arms lengthened. So I think it's a longer conversation than I'm mentioning, but certainly the end result of having achondroplasia does not have to be paralysis or living in a wheelchair or living in severe pain on multiple medications to try to treat your pain that you're having. So I will leave you with that and say that I think this will be followed up by Kristen, who will try to show a number of patients giving their testimonials. And if you don't believe those, I'll certainly open up all of my patients to this. It doesn't come without complications. It doesn't come, you have to finish the process sometimes. Non-union, a pseudoarthrosis, it doesn't heal, then you get it to heal. Whatever it takes to get it to heal, you do that. If another area becomes compressed, then you have to decompress that area and do it in a fashion that does not allow paralysis to occur. Because once a paralysis fully occurs, it's very hard to reverse. So you want to do it when the symptoms are there before the paralysis is there. Okay, that's my soapbox for achondroplasia, spine, and Y fusion today. I hope you're all well, and I hope you're all staying well. Wishing you all a great beginning of the summer. We'll be back sometime this summer. We'll give you a date and post that soon. And I hope to hear from you soon. So I will take any questions live or certainly answer any questions sent to me via email and via the internet. Okay, so have a great weekend, everybody. Take care.